and I'm delighted to host this webinar for you all on the inclusion of families in the treatment and recovery of eating disorders. We're joined today by four incredible speakers who all have varied experience working within eating disorder services all around Ireland. So Dr. Orla Moore, Maureen O'Regan, Dr. John Brennan, and Dr. Anna Moreira. A little bit of housekeeping before we begin. So this webinar will last from 2 till 3:30. It's delivered webinar style, so we can't see or hear you. If you have any questions, please do use the Q&A function, which will be at the bottom of your screen. Just as a note, if you'd like your question to be anonymous, do remember to tick the anonymous box. And we're going to have three presentations, and then we're going to have a Q&A at the end. But please do leave questions throughout if you'd like to ask anything specific. Also, as a note, we're going to be recording this webinar, and the recording will be available afterwards online. So do keep an eye on our social media and our YouTube page. So I'll introduce our first speaker, Dr. Orla Moore. Dr. Orla Moore is a senior clinical psychologist with over 11 years experience supporting children, adolescents, and families affected by eating disorders. Throughout her career, she has worked closely with parents and young people, navigating the complexities of recovery, bringing both clinical expertise and a deep appreciation of the resilience families show in the face of challenge. Orla is also trained as a systemic family therapist. Her approach is firmly rooted in collaboration. She believes that meaningful change happens in relationships, and she is particularly passionate about empowering families as central partners in treatment. Her work has spanned specialist, inpatient, and community settings, and she currently practices within the Community Eating Disorder Service in Galway. So I'm going to share my slides here now for Orla, but you're very welcome. Thank you so much for joining.
Thank you, Christopher. And thanks for managing the overheads for me. I'm not great at multitasking, it seems.
No problem.
So yeah, maybe if you just, I'm obviously just speaking for a short time, so I'm just going to do a hopefully a useful kind of whistle-stop tour through the area of family-based therapies for eating disorders. So maybe just the if you can go to the next slide, Christopher, just the outline. So I'm just going to really just talk a little bit about the origins of FBT, a little bit on the research, the advantages, what it is and what it isn't, and just I suppose the key principles, just so as you're aware of that, and yeah, as I'll be saying in my talk, it's really highlighting the central position of parents and carers. That's, I suppose, different than the individual therapy for adults. This is for young people, and so it is important for parents and carers to recognise and realise that they have a very central position. And then I'll just go through the phases of FBT just to help people have some understanding. So just the origins. What a lot of people may have already realized is that when people are talking about family-based therapy or treatment for eating disorders, the language is often a bit confusing. You can hear FBT, then you can hear FTAN, which is family therapy for anorexia, and then you can hear of the Maudsley approach. So that can be that's very confusing for clinicians, let alone, but it's also obviously very confusing for parents. So just to explain that a little bit, it began in the Maudsley in London, and that's why you'll hear of the Maudsley approach back in the 1980s. When I suppose they began to realize just how more effective it can be if you access the people around the young person suffering from this terrible illness, that if you can recruit the people around the young person, then it can be much more effective. So there was a lot of family therapists in the Maudsley, so that was kind of the origins. Then John Locke, apparently, who's American, American psychiatrist who works in Stanford, spent time in the Maudsley, and then went back and did lots of RCTs, lots of research, really kind of I suppose, highlighting the effectiveness. And he developed his own manual. So there are two different manuals. FBT is the American, FTAN is the English, but there are huge overlaps and very similar approaches. So for families, just to know that if you're getting FBT or FTAN or the Maudsley approach, they're all very similar and very evidence-based. So it is the leading evidence-based approach at the moment. And it's recommended by the National Clinical Programme in Ireland and also in the UK and America. And as I'll talk about, there are different stages, but the first stage, which parents will often experience and talk about, is the initial focus on weight restoration. And that can be confusing for people, especially when psychologists are involved and they're thinking, would we not do individual psychological change focus therapy? But no, the initial focus for the family therapy is weight restoration. So next slide, please, Christopher. So just quickly, the research, it's shown that adolescents who receive FBT recover at higher rates than those who receive individual therapy. So a study in Chicago and Stanford showed that at the end of a course of FBT, 2/3 of adolescents with anorexia had recovered, and that 75 to 90% were rate recovered at a 5-year follow-up. So obviously that's very promising, very positive. There's more research being done now at how approachable and acceptable it can be for young adults to include their families. So FBT is also being used in that age group. And it appears to be most effective for families in which the length of illness is less than 3 years. I'll bring this point up again, but an early positive response to the treatment, commonly by week 4, is very prognostic of a long-term successful outcome. Next slide, please, Christopher. So I suppose just the advantages. Obviously, it's very effective. And I suppose the idea being that this is treatment and support for families while their young person is still in the community, and really reduces the need for hospitalizations, which of course can be very traumatic for a young person. That this supportive structure is within the community. It's non-pathologizing and hopefully empowering for families, that we support the families to make decisions, to support their young person on the journey to recovery. So the whole family is involved, and really hopefully mitigates against relapse. So next page, Christopher. So what it is and what it isn't. So it's a compassionate rather than authoritarian. In the past, obviously, young people would come in and then they would be told what to do and how to get better. This is a much more compassionate and hopefully collaborative approach. Leverages on parents' love and is positive and strength-based. Next slide, please, Christopher. So I suppose the really important thing to recognize is that this comes from family therapy, but it has really moved on from an idea where that there's a dysfunction to be found within the young person of the family. That's not the work that we do. We recognize that the illness that this family is coping with is what we need to focus our time and energy on. And that this illness in and of itself is it's so preoccupying, so stressful, that it can reorganize the family. So what we work to is helping the family to recognize that, to not blame themselves, and to work together against the illness. So just as the young person judges her self-worth by restriction, so interpersonal relationships, feelings, behaviors in families can also become moderated by food-related behaviors. And that's what we try to help families to untangle and figure out and find a way forward. So I just have a picture there of a war. I mean, as many families will know, having anorexia in the house feels like war sometimes. Mealtimes can become so stressful. And for families trying to figure out their way through it, there can become a real difficulty, not just for the young person, but the family, in tolerating uncertainty and in taking risks, the very things that you need to do to get better from an eating disorder. So that's why I suppose we like to focus our attention to everybody in the system, not just the young person. So I suppose once, next slide, please, Christopher. Once anorexia is clarified, it's the illness and its impact that shapes the direction of the treatment. So it's not of the family, but with the family. So it's really important to remember that the illness model is what has been shown to be effective. No assumptions made about family dysfunction. Most of it is working with a family who are trying to adjust to a very serious illness. Um, Okay, so next slide. Just looking at what is how do we facilitate change? What is the process of therapeutic change? So obviously, client motivation, family resilience, therapeutic alliance, they all are very significant factors for positive outcome. That's why there is so much of a focus, rightly so, on the relationship between the therapist, the family, and the idea of developing and um, working to develop family resilience. Um, but I suppose, as I've said already, there is a strong focus in the early stages on behavioral change. So this is consistent with empirical findings that if you can change behavior first, that will then lead to early weight gain, result in much better outcomes. It also will is much more likely to change cognitions. And this is what families often wonder, is that why don't we focus on cognitions in the beginning? We do get to cognitions if we need to towards the end of the treatment, but the early stage, the focus is on behavioral change because that is what makes the biggest difference. So as I said before, studies show that rates of recovery drop by 70% if weight gain does not reach 2.4 kg in the first 4 weeks. So that's a very significant factor. And that's why we focus our attention on the illness and trying to help the family to make changes to ultimately produce weight gain. Parents will say all the time, and I'm sure there are parents on this now that think this, why is there so much focus on the weight? And that is why. Our focus is the changes they have to make as a family, and particularly parents, to make that weight increase happen. So even though we do focus so much on the weight, it's the changes that have to be made at home to result in the weight gain is what we focus on. So families have to plan the extra food. They have to have the food in the house. They have to figure out how they make sure it's eaten. They have to support the young person with the significant distress that happens and is as needed for recovery to happen. They have to learn how to stay calm. They have to learn how to become emotionally supportive, and yet also be firm with the illness in very different circumstances, and do this 6 times a day. So that's the work, is figuring out how do we empower the parents to do that. So early stages is shaped by illness anxiety. So we do need to help parents to recognize that your child will not get better if you don't increase anxiety. And that can be really counterintuitive for parents who understandably spend so much time trying to help their young person with anxiety, and we're asking them to increase it. I suppose there's also a kind of to help to recognize that families at the initial stages are quite dependent on the team, on the doctors, the dietitians, psychologists, but as that moves forward, they become much more central and part of making decisions, in the same way as the young person starts off being very dependent on their parents, and then we move to phase 2 where they take back on responsibility themselves. As I say, it's very task focused. Relationship work tends to happen indirectly. It happens when the whole family are in the room, but it is also important to consider exploration and management of emotions and feelings in the family. Next slide, the maintenance factors, Christopher. So we don't spend a lot of time trying to figure out how or why it happened. What we look on is what's happening within the family that is maintaining the eating disorder. That's where we direct most of our attention. But it's also important to remember that there are lots of strengths and resiliences in families that can be forgotten when things get so stressful. Like, how did families manage stress and difficulties in the past? That's really important to remember and help families to remember. So just as I said, the central position of parents. Next slide, Christopher. And this is true for bulimia and anorexia. Parents often believe when they come in, because their child has become so unwell, often in a way that they didn't fully recognize initially, because they're looking at their child every day, so may not even see the weight falling. They're also dealing with a teenager often. And so the teenager has more time separate from their parents. So that can be really difficult for parents to realize that some of this eating disorder has gone unnoticed, unrecognized, unchecked. So when they come into us, can feel very ill equipped and assume that the professionals are the ones who will cure their gorgeous child. But actually, with time, they begin to realize that they are the person that's they are the family that are going to be there 6 times a day, and that they can do it. It's not about controlling the willful behavior of a child, but an act of care for the young person in the grip of an illness she cannot or he cannot resist on her own. So that's why we do a lot of work on externalizing, talking about the illness and the impact the illness has on the young person. So being firm on the illness and obviously staying supportive of your gorgeous child. So we do a lot of work on identifying obstacles for parents. And this can seem strange, given that the young person is the one with the eating disorder, but given that the parents are the ones needing to provide the change in the early stages, we do work with parents, recognizing that all parents, there are some obstacles for them that are relevant for them. So I've just put some of them up there. I won't read through them, but sometimes there's a fear of alienating other children, a fear that the loved one will be seen as abnormal or mentally ill, fear of pushing the loved one too far with treatment. So these kind of very common obstacles can make it very difficult for parents to keep going. But once we can talk about them, normalize them, figure out ways of working through them, then that can really help. There's also parents will often have concerns about, because we are engaged in emotion coaching our children during this very difficult period. So parents will have, understandably, concerns about that, afraid that if I validate her feelings, it'll make it all seem very real. It might strengthen the eating disorder. I'm afraid that too much soothing will prevent her from becoming more independent. So parents will have very legitimate concerns that sometimes cause obstacles to recovery. So we do spend time, acknowledging and supporting that. So just who, I'm aware I've about 3 minutes. So who should be included? Sorry, Christopher, I'm on who should be included in the treatment therapy. So parents often ask that when they come for family therapy, who's involved, who should be involved. I suppose from our perspective, as many of the family, who are living at home, are, you know, going through the journey with the young person as possible, we would be inviting. It's really very, very effective when we can have siblings who can talk about how the eating disorder is affecting the family, how it's affecting the young person, and affecting them. More and more, we're realizing that siblings can be really negatively impacted by this sort of an illness in their house. So, including them in the journey, helping them to talk about the distress, put names on it, recognize that they have needs too, and also ways of supporting their young person or their sibling can be really powerful work. I suppose we would always insist, if there are two parents, that both would attend. It's incredibly important and has been shown to be one of the factors that increases positive prognosis. A question we got from a lot of parents is, should we not be doing individual work? I suppose family therapy does include work for the individual child, but just in a way that includes their family system around them. Separate individual work is often, not useful, particularly at the early stages when the young person is very severely unwell and has limited capacity for cognitive work. But also it can kind of separate them from learning to put words on their distress while with the very people who can support them at home. So we would really, I suppose, try to include family members and keep as many family members as involved. But also that can include extended family. We'd often have grandparents involved, or uncles or aunt, whoever is appropriate for the particular family we're working with. So I said a little bit about that, but siblings, it is important for parents to recognize and to make decisions about them being involved. Often the young person with the eating disorder may not want their siblings there. They may be so used to keeping these worries to themselves, that the idea of talking openly about it can be really difficult. But actually breaking the silence about this illness can really be a positive thing and result in moving the young person away from isolation. It's also important psychologically for people to learn to put words on distress. So bringing siblings in can be tricky, it can be hard, but it's a very useful piece of work. Um, so just moving from the what to how. We know parents know that that their children need to eat more, but we help them with how. How do you do that? So just these are just the phases. You'll hear about the phases of FBT, and they're really important because the idea is that in the early stages, usually session 1 to 10, but this varies obviously, it is the parents who step in. And that can be tricky at a stage where maybe young people are getting more independent and making their own decisions. It is tricky, but the illness demands it, that the people who do not have an eating disorder and the wrestling with the cognitions are the ones to kind of take charge, to step into care for their child who has this horrendous illness. But that phase doesn't go on forever. Once parents have stepped in and given their child the support they need, and once weight is starting to be coming close to being weight restored, then we move to phase 2. And that is the stage where parents hand back control in whatever way they think is appropriate, depending on the age of their child. They hand back control to the young person. And that can be sometimes a lovely phase, sometimes a really tricky phase, really tricky. Some families are very kind of black and white. And so negotiating that kind of gray area of who does what can be really tricky. And then phase 3 is the other wider family or adolescent developmental issues. So between I'm just that everything is addressed, but it's just done in a way that's more effective. I just put that up there as well because FTA and have 4 phases. It's very similar, but just in case people are a bit confused by that. Just some feedback from parents about FPTs. They felt like they weren't being judged. Having to attend regular sessions ensured you kept the pressure on regarding food when sometimes you might be tempted to let them off. Um, being pushed at each session, believed that meeting as a family, and could see that all of us were concerned for her health and well-being. And just some suggestions. We did a piece of research on this. Some suggestions people asked for: longer sessions for child on her own with the therapist, some support for parents. So we do try to be as flexible as we can so that the whole family are involved, but how we do it. So we may have parent only sessions often. We'll sometimes have sibling sessions, and obviously sessions for the young person, particularly as the therapy is developing for themselves, can be really helpful. So just quick summary. Sorry, I'm not Christopher. I'm so sorry. I'm not making it clear. But the very last one is just final thoughts. So, parents and carers, in your worry and distress, you'll often focus on the child's internal distress and assume that they need individual therapy. With family therapy, very understandable thoughts, but really resist. Come together as a family and talk about how we make the changes, the behavioral changes that we need in the early stage. The most effective people to make that are the carers, the parents. Prognosis improves if both parents are involved. Really, really important. It's a family therapy intervention. Best recovery is when you work with the whole family. And when refeeding is compromised by family issues, then they can be addressed, but only then. Okay, thank you so much. And I'm sorry if I went a bit over time.
No problem at all. Thank you so much, Orla. That was such a great overview of FPT and FTN and how you can include families and how you do in your service. I'm just going to take a check at the Q&A, and there is a question here. I don't know if it's directed at you, Orla. I know you can't make the Q&A, but maybe you have some thoughts. How do you see the future of eating disorders and the review of using a pluralistic modality in the treatment of disorders, particularly anorexia, alongside family support once weight gain has been restored to a safe level? Not sure if you want to add any thoughts on that.
Yeah, I mean, I think it's a great question. And I think, increasingly recognizing that the more people around the young person that we can recruit and inform, the better for the young person. I mean, we sometimes will talk to schools you know, and that's why I say the idea that bringing siblings in is it's really powerful, you know, because in the past they've done research on adult siblings, and in the past they would have been in the same house, experiencing the same level of tension and worry and stress, but weren't equipped with the language to talk about the illness that was in the house. So yeah, I think every effort to you know, for the young person to recognize this is not your fault. You have an illness. Um, and so everybody around you having that knowledge, understanding it, externalizing it, is really, really helpful. Because, you know, there was a talk this morning, I know, from the compassion focused, some of the compassion focused people, and they were talking about that the sense of shame for the young person is so strong that it really impedes recovery. So the more people who have an awareness of what the young person is dealing with and that this is an illness and not their fault, I think the better for recovery. So hopefully, I suppose that's the idea of family therapy. And I suppose what we would love and wish for is that there are more families involved for the adults once they transition to adult services.
That's so great. Thank you so much, Orla, for joining
Thanks,
us
Christopher.
today. Really, really appreciate it. I'm going to introduce our next speaker now, who is Myrna O'Regan. Myrna O'Regan is a senior mental health social worker who has worked with St. John of God's Hospital since 2014 and has been part of the Eating Disorder Recovery Program for the past 5 years. Myrna is also a registered systemic family therapist with a specialist interest in the area of eating disorders. Welcome, Myrna. Thank you so much for joining us today.
Thanks, Christopher. Thanks for the introduction. And what a great presentation, Orla. I was enraptured by your slides, so I kind of forgot about presenting myself.
But thank you, Myrna.
A lovely segue into a lovely segue into.
I hope I haven't taken too much time. I was watching time, so I'm very interested in listening to you, Myrna.
Oh, thank you. It's wonderful to see so many people here today. It's such a privilege to be invited, and Orla gave a nice segue there into the adult services. As Christopher mentioned, I'm based in John of God's Hospital, which is an inpatient based program. The EDRC stands for Eating Disorder Recovery Centre. And we can move on to the next slide there, Christopher, please. So to say a bit about the context here, we are a national service, so people can come from all corners of the country, and they are often coming where they are leaving family homes from a long distance. So we're very conscious of that, the journey here. We are a 12-week program. We have people from the ages of 18 up to 80, so across the lifespan. And we have that 12 weeks, we have varied amounts of time that people may be here in hospital for. That's I suppose the way the program is orientated in the 12 weeks, but people are often here longer. So we have different models of care and an evidence base for working with adults and their families rather than children, as Orla was very excellently outlining there, the FBT and the family-based treatment model with children and adolescents. When we're meeting with people at varying stages of their life, we're thinking of their relational context. So it may be that they're married with children, they may be a young adult living outside of the family home. They may be, at a later stage in their life with adult children of their own. So we're meeting people at, different phases across the life course. And we're always thinking relationally and thinking of those close relationships and families. And as Orla was speaking to, the devastating impact that an eating disorder can have for the people around the person and those who love them. And we are person-centered, so we're working with the individual, but we're thinking broadly from day one when we meet them. And we're thinking of who are the people close to them, who are their supporters, and recognizing that ultimately recovery happens outside of the hospital context. So there are sometimes competing needs, the families maybe real, genuine, understandable need for information, are building a therapeutic relationship with the person in what can be a quite frightening experience for them coming to hospital, possibly for the first time, their need for privacy to be respected, and that therapeutic relationship and the centrality of that at particularly the early stage of their treatment. So the next slide there, Christopher, please. So I decided to illustrate this in the pyramid we can see here, that at the very bottom of the pyramid, so we are meeting the person, we are thinking about the relationship, and as Orla mentioned, often at the early stage of the person coming into treatment, they may be very physically compromised, and the focus of treatment is on the physical stabilization, weight restoration, and alongside that, building a sense of safety for them with us in the hospital environment in relationship with us, and building a working partnership when they're being asked to do things that are very threatening and frightening for them, that they feel a sense of safety in the relationship with the team. So the focus is on building trust, and that is a key foundation from which we then can continue the treatment. So the phases are similar in that we talk about phases of treatment throughout the program, but the first phase is on that depending on the person's needs and physical stabilization. And then we have a group program. So as part of that group program, we have a family support group, which has been running since the inception of the EDRC. This year's 30 years, and the family group has been happening here in the hospital. And the focus of that is the next tier up. So we'll with the person's permission, make contact with their close supporter. We also use slightly different language in the adult services. I know Orla was referring to carers. You know, you can imagine if this is my husband, or this is my sibling, adult sibling, or my adult child, we use slightly different language than carers. We'll call them supporters, or whatever the person might want them to be referred to as. So the making contact and considering the family's needs. So we're at the bottom level, building that relationship with the individual. What do they want and need in terms of their relational network and their support for those people, and then making the contact with the family and what it is they want or need. And it may be that they've been through many episodes or experiences of treatment in the past, possibly have done the family-based treatment in their child's adolescent years. And so I really want to understand what they are hoping for, what their needs are. There is always the open invitation when the person has nominated, they can nominate 2 people to come to the family group. And that's an open group, so it rolls every week. And we're very conscious of people's commitments and the distance coming to the hospital. So families are really incredible, driving 3-4 hours to come to spend time with their loved one at the weekend. We're mindful of that journey and other commitments that they have in their life. So the group that we run is an open door policy. So once we have some sense of when they'll be able to come, they're welcome whenever they can make it. And we bring different ideas, and the focus is on psychoeducation and sharing resources and learning together. And I suppose the power of meeting other people in similar having similar experiences with their family members. So we will pick a theme for the week. We'll focus on that, maybe theme in resources that we can bring along, or conversations that we have that can bring up more questions. And we will then maybe at the end of the group say, how about we focus on that next week? And often, you know, someone at the group will have maybe done a training or come across something they found really useful. And we're also conscious people are at different stages of recovery. So someone will be at the group and their family members coming close to the end of treatment, so they've got wonderful advice for the person maybe whose family member has just joined the program and that different phase. So then in that next phase of active involvement of the family in treatment, we have the option for family meetings, and I'm often in contact by phone given the distance for some families. And then we've another phase up. So family meetings can be involving myself. As Christopher mentioned, I'm also a family therapist. So we're maybe thinking about how the family has been reorganized by the eating disorder, the impact on them. Sometimes it's a couple, sometimes it's, as Orla mentioned, siblings come in. So whatever family looks like for that person. And the psychoeducation element might involve the doctor joining for some of those meetings. And then in the top tier, we have, for some families, after the physical stabilization phase, as Orla was saying, when the person can engage therapeutically, and I always think equitably, if there's one person in the room who is in extreme distress and not in a place that they can process and reflect, and other people in the room can, I'm always mindful of that it's a space where the person can be, often as an adult at that developmental phase, actively involved. So the latter phase of their admission, we might begin family work, and then we have a family therapy service in the outpatients here that people can choose to be referred on to continue that work in the outpatients. So hopefully my pyramid makes sense. The top bit's a little bit wobbly, not sure what happened there. So Chris, for the next slide, please. So I thought to present a hypothetical case study to give a sense that when people arrive into hospital, we meet them. Often their family member might accompany them into the admission meeting with the doctor, and this scenario that I presented is not any one individual, but it would be a situation that we'd often meet. So I've represented there the sunflower seed. So I would often picture those first meetings as we're planting the seed. So that can be planting the seed about who is close to you, asking those relational questions, and thinking of them in their context of family, and then throughout the admission, tending to that. So, hopefully that will bloom into the very, potentially the top tier if that's what they want. So meet Mary. So Mary's 27 years. My little bird there, apologies. She's arrived for her first admission to hospital. She says that she doesn't want to do the program. Her parents have made her come here. She's very angry with them for forcing her into hospital. She's upset and tearful, and she doesn't want her mum involved in treatment. She's very distressed. And so alongside that, Mary's mum, Bernice, she's phoned the team secretary and asking urgently to speak to the doctor. So, your heart goes to Mary, it goes to Bernice. You can see both of these women's distress, and I'm going to then work through how we might journey through with Mary and Bernice in treatment. So just the next slide there, please. So with Mary, so the very first phase is her getting to know me and the team, and the people on the program will meet with us, pretty much on a daily basis, and they're getting a sense of who we are and building a therapeutic relationship. We have a group as part of the program called the Interpersonal Relationships Group, where we'll think about their relational world and how that's been impacted by the eating disorder. And they start that group from the beginning of the program once they're physically well enough to be coming down to the group room. So I bring systemic ideas, bring in some communication skills, and often it's a journey for them around expressing their emotion and expressing their needs. And within that group, often they'll bring those close people to them and how the relationship has been impacted. And Mary joins that group in this scenario, and then having got to know me a little bit and heard about the relationship group and how we're thinking in that way, she asked me to give her dad a call. And then I'm in contact with dad. I give him an open invitation to be in touch with me, and the line of communication is now open. And then as Mary continues to settle, she nominates her parents to attend the group. Thankfully, they're in a position to do so. And often they'll hear from each other. They're together every day, the group members. They might hear, my family's done the group and they really found this benefit from it. And so, that they might be getting that kind of feedback that they think this could be helpful. Then at the point where Mary's having some weekend leave, she's thinking about how to plan the meals, and she decides to have a family meeting organised that she thinks that would be helpful for everyone. Then in in having that meeting, Mary decides that some family sessions to rebuild communication with her parents would be useful, and then we can work towards an ending where a referral is made to outpatient family therapy service when Mary is leaving hospital. So that's, I suppose, a run through of Mary's journey. And just on to the next slide there, Christopher, please. I'm conscious Orla was great for her research and her putting in all the references at the bottom. I suppose the world of research in working with families where the person is an adult, there's a lot less evidence. There is some evidence around attachment perspectives and narrative approaches, which are both systemic theories, but there isn't a large, robust evidence base for a particular approach in working with adults in the area of eating disorders. And so I will often use a very tailored approach to that person and that family's needs, and I suppose bring that curiosity to meeting with them, and as Orla was saying, positioning myself in a systemic way. So then Bernice, as she's on the ward coming to visit Mary, she gets to meet the nursing staff. That's reassuring for her to see who's involved in looking after Mary, to get to see, her bedroom where she is. That's reassuring for her. And the nursing staff will always explain to the person visiting, a bit about the policy on visiting, and they, in that conversation, suggest that maybe Bernice could write a letter to the team outlining her worries. That's often something family will do when they have, that very extreme distress and worry, and they want to be able to communicate those worries. And so Bernice decides to write a letter, which is often then scanned onto a system here that we can all access and read through and discuss. And then when the contact's made with Mary's dad, Bernice has that reassurance. She can pass on questions through him to the team. And Bernice is having the experience of hearing from Mary, her progression through maybe the initial phase of weight restoration. And in my communication with Dad, I'll always pass on a list of resources. So that would include Bodywise and lots of other organisations who can support families within Ireland and abroad. And then they decide to do the pillar programme, which I imagine some people here have got to do before. And we always get really, really positive feedback from parents and other family members who've got to join the pillar. So then the family come along to the group. They get to meet other people who they can relate to and share their experiences and share their knowledge and wisdom. Then we get through to the family sessions with the goal of rebuilding communication. And similar then at the ending, the referral on to outpatient therapy service, family therapy service here in the hospital. So that's I suppose a run through what is often the way that we would meet with families, and I suppose what that might look like in an inpatient setting. So just the next slide there, Christopher, please. So I suppose just to finish, we're always thinking in terms of close relationships. I've come from the ward round this morning, and often I might be the voice of the family, bringing in a question or advocating on their behalf along with the person, and maybe planning around weekend leave, planning particularly towards that transition home outside of the hospital context. And this is a quote from a woman who's written about her experience, Jenny Schaefer. It's a book called Life Without Ed. She actually has a chapter where she says that having written 3 books about eating disorders, her dad, I think, still says to her, I don't quite understand eating disorders. They are so complex. And I always think not to assume that they're the same for any one person or any one family. And just Jenny's quote here, that no matter what happened, how many times I fell down, they kept saying, you can do it. And in my experience, families can be that wonderful source of hope for their loved one. Their love and their belief in them can be so vital and so central to the person's continuing going through the incredible challenge they're facing in recovery. So yeah, I'll finish there. I probably talked so fast I did it in less time. Did I, Christopher?
You were perfectly on time, Erin.
Oh,
Thank you very
there we
much. What a fantastic presentation. I'm really struck by the tiered approach. I think the pyramid is a great way to show how you can include families and the flexibility, and depending on the person and individualize the approach. So thank you so much, Miriam.
Great, thank you, Christopher. Thanks for the opportunity. Bye. Or I'll still be in the background.
Yes, stay for the Q&A. So we'll go on to the final presentation then for this afternoon before having the Q&A. So I will introduce our final speakers. So we have Dr. John Brennan, who has been working as a clinical psychologist in adult mental health services for more than 10 years, the past 2.5 years of which has been with STREAM, which is the Regional Adult Eating Disorders Service for the HSE Southwest, Cork and Kerry. And then we also have Dr. Anna Marira, who's been working as a consultant psychiatrist in adult mental health services with more than 10 years experience. Similarly, the past 2.5 years of which have been with STREAM. So delighted to have you both here with us today.
Thanks, Christopher.
Thank you.
Just as a note, do take your time if you'd like to run to 3:10 because we were a bit late.
Thank you.
Thank you.
And thank you for sharing the slides on our behalf as well, Christopher. Much appreciated.
Thank you, and thank you to all that Bodywise has been doing for people with eating disorders and their families, carers, and all significant people. The Bodywise is a partner of the National Clinical Program for Eating Disorders, which has been growing and has now multiple teams, teams with that are more with children, teams that are more with adults throughout Ireland. And these teams, many of them didn't exist previously. Our team exists for about 2 to 3 years at the moment. And many of them serve a very large population area, catchment area. So our population area would have about 750,000 people at the moment, which can make it difficult for people with eating disorders and families to participate. Our contact details are there. And I don't know if you wish to say anything else about
I suppose just in the overall scheme of things, STREAM is a very recent development within the HC Southwest mental health services. So like Dr. Marira was saying, we're only in existence with the past couple of years. We started accepting referrals about 2 years ago, and we've been growing since. We initially accepted referrals from consultants, very quickly started accepting referrals from GPs, and the service has been expanding since then. I suppose in that time, there's been a huge amount of learning on our behalf. Personally, sometimes I feel the more I learn, the more I realize I need to learn. So I think going forward, there'll be a huge amount of development ahead of us. We're, I suppose, considered a very young service in many respects. So I suppose really what we're hoping to do today is just to demonstrate or to explain where we try to involve family members in the service so far. Within that context, we're very much aware that as the service develops moving forward, that there'll be more and more opportunities for that, hopefully. So that as time goes by, we'll be able to develop the service in such a way where family members feel more and more included. Next slide, please, Christopher.
So in terms of how to involve families and carers and significant other people, there is a big difference between children and adults. We've heard 2 amazing presentations before this presentation. The first one focusing on FPT. FPT is many times not the first choice for our service, though as we've heard this morning, most people presenting to the services across the National Clinical Program would have below it's 25 years old, though obviously there is the eating disorder can be at multiple ages, particularly when these services were not available in many years ago. And so adults have to consent, and many times have to consent to the treatment, but also for the involvement of other people. they also have to consent to the referral to these community eating disorder services that are many times an outpatient services.
I think probably from the perspective of children versus adults as well, at that younger age group, we're very mindful that we say, because we work with people, as soon as they hit 18, they might be linking with our service, they might have been linking with the child and adolescent service prior to that. Our development doesn't take a huge turn or a big step forward between the last day of being 17 and the first day of turning 18. The person is still very much the same. But the law does change, and all of a sudden they have a lot more. I suppose there are more considerations from a legal standpoint in terms of confidentiality. They have much more autonomy from that standpoint as well. So I suppose there's a piece there where managing a transition like that, families can be really important there in terms of supporting that piece. And yet at the same time, it can be a very difficult transition, because where a family maybe felt that they could be more supportive up to that point, all of a sudden the person might feel that they have a lot more autonomy over their decision making, which might be in conflict with what a family member might feel or family members might feel is in the best interest of that person. So there can be a lot of negotiating around those pieces there, and in terms of, I suppose, supporting the person around this sudden, I suppose, acquisition of autonomy that they didn't have prior to that, and supporting family members around that piece then as well, while respecting the rights of the person who is now an adult.
One of the aspects that we much appreciate in the team is that because so many very young people are presenting, there is a huge scope to facilitate transitions. There are a few teams co-located with their CAMS eating disorders teams. We are very lucky to be one of those teams, and from time to time, we have meetings with our eating disorder children and adolescent co-located team, and when possible, we do joint assessments. This is not always possible, but it has been in some occasions, and we feel this much facilitates the process of the transition.
I suppose in terms of the limits of confidentiality, where possible, obviously we will try to keep family members updated on the progress of their loved one. Again, I suppose because you're dealing with adults in this service, like, it's very much within what will that adult consent to, what information will they allow you to share. Which I suppose, when you think about it from the point of view of family, and particularly those who've been very involved with, if this has been occurring since the person was under the age of 18, it can feel, I imagine, hugely disempowering not to have information. If we think back to any point in our lives where we were awaiting the outcome of something and you didn't know what that outcome was going to be, and you're kind of in that space of not knowing, that can be hugely disempowering and hugely anxiety provoking. So where we can within the service, while we try to, as best we can, to respect the limits of confidentiality with the person, at the same time, you're also mindful that the person doesn't exist independent of the system around them, that the whole system works in tandem, and that I was trying to work with the person to see where would they be willing to allow family members to be involved. And it was really, it's looking for as many opportunities as we can there, so that you're kind of supporting that system where you can, rather than supporting the individual, and I suppose trying to prevent all the anxiety and all that distress building the system around them. Because ultimately the picture that tends to develop is that the person, again, not independent of that system, they're going to be picking up on all of that, and they're going to be absorbing that as well. So you start to see these cycles that develop that aren't good for the other people in the system, the family members, or for the person themselves. And there was just a comment I think Orla made earlier about breaking silence, and silence can be a huge maintenance factor in terms of like shame and other obstacles to making progress, and kind of having the family members involved at any level that you can, breaking down that silence and breaking down those barriers as well, creating that shared understanding. I suppose every contact that you have with family members, there's an opportunity there for learning and understanding each time, I suppose, making every contact count in that regard. So I suppose from our point of view as an adult service, and I suppose I'd encountered this when I worked in general adult mental health as well. And while we tend to provide a lot of individual interventions where opportunities arise, we do like to involve family members and kind of work in that more systemic way where possible, even within interventions that are primarily designed to be delivered individually. So, for example, if you take cognitive behavioral therapy enhanced in the stage 1 phase, there is a part of that where there's space created that if you can get family involvement there, that you do get family members involved. And in other modalities as well, I think from a psychological perspective, when we're trying to generate as good a formulation as we can as to what's going on for the person, getting other perspectives on that can be hugely, hugely informative. So while we try to respect the limits of confidentiality and the person's autonomy as best we can, we do try to counterbalance that with family involvement, because we do recognize it's so essential to people being able to make progress and overcome their eating disorder.
In some cases, that has meant supporting families directly, and there's always this trying to understand the wider system, the wider network. When it has been possible to the team to do this, we have been creating this space to support families directly. And here I wish to very much thank Bodywise, because they have this really good programs for families, for carers, for people to attend. And we hear the feedback on our side as well, that they can be so supportive, they can be so good to help the people with eating disorders themselves.
So I suppose in a practical sense, if we're looking at kind of the different ways in which we kind of involve people, family members might get in touch with queries when a person's been referred to the service. I suppose what we just need to establish there is that the person who's been referred has consented to us being able to communicate with families. When the person presents for initial assessment, we always invite them to bring somebody with them. I suppose we're always mindful that the more perspectives you can get on any problem going on anywhere, and you get more of a rounded view. So we do always create, or I suppose extend, that invitation to people to bring somebody with them to the initial assessment when they first come to meet us, which is quite an extensive assessment on the morning. And even in situations where people haven't brought someone with them, but where they are comfortable with us getting collateral information from like a family member, we've tried to maybe accommodate that in such a way whereby the person might phone them at the end of the assessment and ask them if would they mind taking a bit of time out to give us some information, and then they might be put on loudspeaker on the phone in the room. And I suppose the reason that we work it that way, it's about creating that transparency. And I suppose like it can be really helpful to get that collateral information, and even to get that person's perspective on where do they feel a service like ours could be supportive of their loved one or their friend or whoever it might be. Because a person will come in and they'll identify for us what's going on for them, and they'll kind of see kind of what they like to get from the service. But it can also be hugely informative to speak to people who know that person really, really well, who can view the problem from a different perspective and can give us maybe an idea as to where they feel we can be of help as well. So the initial assessment is another step where, I suppose, another part of the process where we can involve families. Now, where somebody mightn't have maybe that availability to call somebody if they haven't brought them with them, what we've often done is ask them, can they speak to someone that they would feel comfortable with us chatting to, and maybe contact us back with a date and time that would be good to contact that person, and we'll facilitate that then as best we can. Because I suppose that is the value that we do place on getting that input from as early on as we can at that point of assessment, and then moving forward into the interventions where we can as well.
This tends to happen at psychiatric reviews as well. It is not the focus of individual therapy for most of the individual therapies we have to bring families, in carers, in other relevant people. This is because it is the person with the eating disorder that that many times has to go through, has the responsibility to go through some tasks to recover from it. However, there are other points of contact in which contact can be facilitated. Something else we do, and we've been having incredibly good feedback in also outcomes, are integrated care plan meetings. In integrated care plan meetings, the person themselves will let us know if they feel comfortable to bring somebody else.
The thing with the integrated care plan meetings is, from our point of view, they're a brilliant opportunity to bring everybody involved in the care. I suppose the way it works at the moment is that the way the team is set up, we're reliant on GPs to do medical monitoring on our behalf. We don't have a consultant physician on the team. We don't have direct access to eating disorder beds, so we're reliant on the local regional or the local hospital to provide beds for us in that regard. And I suppose those admissions are always on medical grounds. So it's still maybe fractured in a way that we don't have a fully comprehensive service. So the integrated care plan meetings can be very helpful to bring those different people in, including the family members, who maybe can get a sense as to the different professionals who are working with their loved one. I suppose the other thing that I'm quite mindful of as well in those situations is, given the geographical spread, we may have a lot of people in the room, or we may have a number of people online on the laptop if they're able to join the meetings remotely. If I was going into a meeting like that, I think I'd feel quite intimidated by all those professionals in the room. So there are times where it's not just about that piece of around gaining collateral from family members, but it's also around that piece of them being there to support their loved one within our system as well. Because I suppose what we need to be mindful of is that we've now become part of that system, and I suppose it's trying to be mindful of that when we're interacting with people, regardless of family members or the person who we consider our client, that we're doing that in a way that always feels supportive and safe. So with the integrated care plan meetings, so we always welcome the involvement of family members, not just to give us their perspectives, but actually to be there for the person as well, and to kind of be their support in that moment.
And talking about support and the wider support, body-wise, the National Clinical Program for Eating Disorders, the support is at different levels, but it is available, and it is available for people with eating disorders, and it is available for people that know people with eating disorders and want to support them better.
And I suppose, in terms of our own support, we've been very, very lucky in that we've also been able to avail of some training from Bodywise. Harriet Parsons has been fantastic to our team. We really, really value the input. And I think it's great to have that. I suppose I would see us as quite a young service, and because Bodywise has been in existence for so long, to be able to tap into that wisdom and form a relationship as well. Like we're working collaboratively. I suppose where we would probably find that the focus is still predominantly working with the individual, to know that there's a partner body with so many resources that can support the families, and that over time maybe we can integrate these things more and more, so that as our service develops, maybe we'll be able to provide more for families as well as individuals, but actually doing that in conjunction with a body like Bodywise, and looking forward to maybe at times at the moment where we maybe feel very supportive of Bodywise, that maybe it'll get to a point where that feels a bit more reciprocal, and Bodywise will feel supported by ourselves as well, and the person, and importantly the family members too.
Thank you.
Yeah, so that's us, Christopher. Thank you very much, everybody, for your time.
Wow, thank you both, and really appreciate that. I'm sure Harriet would appreciate that too, so thank you. We're also very appreciative of the link that we have with your service, and thank you for sharing today. So we have a good few questions that came in through the Q&A. So Miriam, if you'd like to come back on too, if you're ready.
Yeah.
So there are a few questions here. Let me go through. So question from an anonymous attendee. How can my husband and I move away from enabling supporter to that of just being our loved one's parents? We are 20 years engaging as now we understand as enablers, but our child, regardless of their age, 42, is our child. We live in the Northwest area and there are no support groups near us. Not sure if anyone has any thoughts on this.
It's a really important question, and I think it was in my mind as we're speaking about involving families in treatment. There are parts of the country we live in where there are no services like Stream. You know, people don't have access to John of God's hospital and other networks of support. So it can be, from what I've heard families describe, very isolating, and I really need to think about that question. There's layers to it about the concept of enabling and what maybe they mean by that, what that's like for them in their relationship, and to be that 20 years, I think they're saying in their experience with the person who's 42, that, yeah, it's a complex question. I wish I could give a straightforward answer, but I think it's a very complex one. And just my heart goes out to people who are in the country without support, maybe for their loved one as well as themselves. I think there are resources. I'd be happy to share, Christopher, maybe a list of resources that family from our group will recommend, where maybe they're moving to a different position in their relationship to the person. And I'd really endorse that the wisdom of families as well in using their own intuition in their knowing of what's helping, what's not helping over time. And maybe it sounds like they're at a juncture or a point of transition and saying they want to have a different relationship. And I know family members sometimes have gone to individual therapy to get support for themselves, and living through that for 20 years. My heart goes out to them. And as they're saying, they're in an area where there's no support groups nearby. I don't know, John or other people want to speak to that.
I suppose that's really difficult when you're geographically kind of located where the resources aren't being provided locally. And I suppose within the context of that, I might be trying to tap into what might be available maybe remotely. It's not an ideal option, but I guess it's probably working with what is available to you as best you can. And I suppose there's a piece there where, like, that family members are experts by experience in their own right, and you know the person really, really well. You're an expert on them too. And I think there'll be a sense there as when you're in that process of kind of testing out where can I pull back and where can I not, you'll get a really good sense as to what works and what doesn't, based on your own expertise. And hopefully in that time, services will develop. More will become available, but it might be in the short term, maybe trying to see what might be available kind of maybe remotely to start with. And hopefully if maybe something might develop within the area as time goes by that would be more accessible kind of more locally. But I suppose on a practical level, that's probably the main way that I'd be looking at it myself at the moment.
Thank you both. We had two questions here, I think, for Orla, who unfortunately had to step away, but they were asking, how do we access FBT and where is it available? And that would be accessed through a referral from your GP into your local CAMS or specialist eating disorder service in your area. Another question here from an anonymous attendee, who is asking, what is normal in an outpatient situation for an adult, no previous treatment, 10 years of eating disorder? At what point would you expect the family to be included, particularly when the person with the eating disorder is curating any contact with the care team? Thank you.
I suppose just from an adult perspective, again, we're very much limited by what we can do from a legal standpoint in terms of us being able to approach a family. The one thing, though, that I would say is that families can always approach a service, though, with concerns. What I would say there is I would try and keep that as transparent as possible, because I think one of the reasons a person, this is just me thinking the broadest sense, but one of the reasons a person might maybe limit contact with a family or the information that they're giving to a family is to try and manage the situation or keep control of it. So what I would say is that I would encourage families to contact the service if there's any concerns, because there is no breach of confidentiality if they come to us. And it's just that we can't disclose information that the person hasn't given us permission to disclose. But we can bring that to the person then and have conversations around that, and that's why we would always ask people to be mindful that we need to keep that transparent. If people contact us with concerns, we need to be able to have that discussion with the person, so that we're kind of, I suppose, moving away from any fears that they might have that anything might be happening that they're not aware of, or that people might be doing things behind their backs. That while transparency can feel really uncomfortable, where people might feel, oh, if I contact GE and they become aware of that, this might create a barrier at home. But that as time goes by, as the person learns, people aren't going to do anything behind your back. Everybody wants to collaborate with you. That in itself might become an enabler of recovery.
That's great. Thank you. Thank you so much, John.
Christopher, could I just mention, I was thinking about that other question. There is some resources on the Maudsley Kent. If you go onto Maudsley Kent website, there are some resources for adult sufferers and their families. So there is a section on enabling. I don't fully agree with that language. I think it happens within the reorganization of the family around the illness. But of course, that if that's the person's experience, that's real for them. But there's a couple of worksheets you can go through about what, how you might experience that as enabling or facilitating eating disorder behaviors, and then doing a kind of a self-assessment and some techniques and skills. So that might be a resource. If you type in Maudsley Kent, I could put it into the chat there. And then there's, in resources, they have a section on for adults with their family members.
That's great, Muireann, and also just reminds me of plugging our own Maudsley workshop series. So we also run them online here at Bodywise, and of course our Pillar program. And we have varying support groups, theme support groups. So also do reach out to us here at Bodywise if you'd like to avail of any of those services. Thank you for popping that in, Muireann. There's a comment here from an anonymous attendee saying that they're questioning the thinking of an undernourished brain not being capable of benefiting from psychiatric work done to address an underlying cause of anorexia, particularly if PTSD is the root cause. Just wondering if any of you had any thoughts on this.
Yeah, I'll just read it through myself there. I'm thinking.
I suppose.
Yeah.
Go ahead, Muireann.
Yeah, I'm happy to speak to that. So we often families wonder about that and question it, and I completely see their perspective on it. Particularly where there's significant trauma or PTSD, as that person's referred to, and working with the body, working around that trauma and in a trauma-informed way is so vital. And the working more psychologically when physiologically the person is maybe in a state that the mind can't process, reflect, and hold psychological theory and work in that way. It can be, I suppose it's not. I can see completely why people question the thinking, but the evidence base would show that from day one here we are meeting the person in a trauma-informed way. We're thinking of safety in this context and the environment, and building the relationship and introducing them to psychological theory. So as I said, they're in my group from week one, the interpersonal relationship group, unless they're on maybe bed rest and for life-threatening reasons. So yeah, it's such a common question, and I can, and often families will say, but how can they, maybe it might be that the person has been excelling in their work or in college, and they're thinking, how can they not then? And there's the understandable desperation for them to get that support. So I think, yeah, I don't know if I'm explaining it that well, but certainly we are working in a trauma-informed way, and also thinking in terms of the, introducing skills and techniques and distress tolerance skills from day one with the person, that, the focus isn't just on the restoration and just on the meal plan, that we are all mental health professionals, and we're all hopefully bringing that into the treatment for them from when they arrive here. Yeah, so I don't know if that answers your question, but it's very understandable. It's probably one of the most common questions that families bring.
I might speak to that as well, if that's all right.
Yeah, go ahead.
I suppose, again, us being a young service, I wouldn't say I'd be as experienced as other people that could speak to this. But therapeutically, I suppose we do kind of come across situations where if a person's physical state deteriorates enough, they're not able to engage as well with therapies. And I suppose, if you want, one way that I think about it is that we say, if you're looking at working on emotions, so emotions are biologically built into us, and in order to manage them effectively and to reduce our emotion or our vulnerability maybe to having difficulty managing emotion, our body needs to be maintained to a certain level. And when it goes below that level, it does become more difficult. So the person has less resources to draw from, if you want to think of it that way. Another way that I think about it as well is that not all information is equal. So, Joe, there's some information that's very concrete, 1 + 1 is 2, and we can work much easier with that kind of information. Within therapies, we're often asking people to work with abstract information. If you think about talking about an emotion, I can pick up a bottle there and I can hold it in front of the camera. I can't pick up anxiety and hold it in front of the camera. We can often talk about maybe abstract concepts that can feel quite complex at times for people. So as those personal resources are becoming more and more depleted, I do find in therapies, when people's BMI, not exactly for everybody, Joe, there isn't like one number that I would pick and say it's right across the board. When the person goes below that, they can't engage. But definitely you do observe that as people, as those physical resources are becoming more and more depleted, their ability to engage with the demands of a psychotherapeutic intervention do become more and more compromised. And then it does maybe shift more to, we need to focus on a physical rehabilitation to put them back in a position to re-engage with the more therapeutic type work. But again, I suppose that can be more individual, like that there isn't one number right across the board that I'd say everybody responds equally at that BMI or at that weight. So there can be an element of maybe testing limits of people, kind of working with them until it becomes evident, yeah, they're just at a position now where we need to shift focus for temporarily to get them back to that point physically where they can re-engage more successfully.
That's really helpful. I think that's a great explanation. Thank you so much, John and Marin. Just looking at the time here, we might have a few more questions. So, well, Harriet's just saying here that John and Anna's discussion of managing boundaries and confidentiality and sharing of input was really helpful. Thank you. And thank you for your kind comments, Harriet. So when, if ever, can I consider my weight restored daughter who has anorexia recovered? Thank you.
Maybe the first question I just saw Harriet had put in about the language we would use would be accommodating the eating disorder, and we can see how that happens over time within family systems and how it affects the organization of the family. And it sounds like the people there are questioning, they're beginning to wonder, how is this become the way it is, and how do we want that to change, or how do we want that to be different? Those families who are in service, be it the person's with their GP or with consultants within our hospital, they can opt to refer into the family therapy service in the outpatients. So that is an option now. Unfortunately, you have to be linked in some way to a service provider, and so GPs can refer in, and of course, if you're within the service, that you can be referred for family therapy in an outpatient basis. And the question there about when can I consider recovery? Yeah, it's such a complex question, but it's different. I would see it as different for every person, and maybe I'd wonder how that person themselves would define recovery for their daughter, or what would, there is research around recovery from anorexia that's more longitudinal. I know some of the studies are based on within a 5-year period. There's a study that looked at over 20 years of a life course for somebody, and the rates of recovery go up to 67% in and around that. And they began that study 20 years ago or longer now, actually. So hopefully the services that people are getting now, or the types of interventions, are more advanced. And so there's certainly, I would always hold hope for everyone's recovery. But yeah, so individual and unique, I couldn't define it. That study looked at the quality of life and lack of symptoms, the longitudinal study. Yeah, so I hope for that person and their daughter for that. Yeah.
Would you like to add anything, John or Anna?
I suppose just to say that when a person has been through an intervention, or depending on what point they get back to, I think a lot of it can be the point at which maybe something translates into behavior. So if we've ever been through an experience in life, and especially if you're thinking about it in like a trauma-informed way, like that doesn't just get erased because it's happened before. It's always with us in some way or other, and I suppose that can always crop up at another point again in our lives. And for me, there's a piece there around, if I had been through something earlier in life, it's not that I'm just going to wipe it from my brain or forget about it, but hopefully be able to engage with life in such a way where I can manage it successfully. So I think if we think about recovery, about getting to a point where we don't think about these things at all anymore, that's probably an impossibility, because that almost requires wiping our memory, so to speak, or a complete reset. I think recovery for me is getting to a point where I can have a thought, or I can experience a difficult emotion, and I'm aware of it and I can hold that peace, but it doesn't necessarily translate into what I'm doing in my day-to-day. So if that anxiety creeps in around, if I have that and I have that thought, is that going to make me gain weight? That there is that other part of me that can kick in and say, okay, there's those old thoughts kicking up again. Let's not go with that. This is your lunch, just have it there today, or whatever it might be. So that I suppose recovery, often we can think of it as like a fine line. You're either there or you're not, but actually it can be quite dynamic. Maybe there's days where I find it harder to manage those thoughts and those emotions and those urges, and there's other days where things are going easier for me and they hardly feature at all in my thinking. So I think if we think of it as a fine line, we're probably moving away from the concept of what recovery is. It's more of a dynamic kind of state of being, if that makes sense.
It does. I think that's something that we talk about in Pillar, that the idea of framing recovery as like a destination that you're trying to get to can kind of contribute to that all or nothing eating disorder thinking. So rather, as you're kind of saying, something dynamic or something that's more active, like a verb that you're kind of choosing or you're working towards, is a really nice way to think about it.
Thanks, Christopher.
One more question here saying, why are services you're offered based on your CHO area? I've been around the block trying to get access to referrals after referrals, and I'm kind of losing hope. What could I possibly do to get the access to services that I need? Not sure if you'd like to comment.
So I suppose that would be the GP would be the first point of contact, and then there is advocacy out there as well, which I believe is one of the role of Bodywise in the National Clinical Program for Eating Disorders. People can advocate as well for themselves and to request resources. When teams are designed, and the way they are designed designed to serve a specific population, and to collaborate more closely with that community, and to promote connections mostly in those communities. So I believe it would be a lot of advocacy to bring more teams to Ireland and more resources to help people with eating disorders and their loved ones.
Yeah, I suppose unfortunately that's a byproduct of the way services are set up in Ireland, that everything from regional health areas down to individual community mental health teams, that they're all designed to service a particular catchment area. And I suppose at the very basic level, the idea behind that is to make the service more accessible so that regardless of whether I'm in Kerry or West Cork or North Cork or wherever, that there'll be a community mental health team that I can access that's relatively close to me. But definitely I think as these levels go up and as the areas get bigger, so like a regional team, the dynamic can change there quite differently, but that isn't reflected in how like services are structured, the way that they're structured, and it can feel very exclusive from the point of view that if I'm not living in one of those catchment areas where a team serves, unfortunately, then it's what's the term? Is it the postcode lottery? Yeah, and that's the real downside to that. Then that I suppose providing a structure means that services can be developed accordingly, but then it can either be very inclusive or exclusive.
We do have a step model of care. In obviously it is there are levels that people can access, but for instance, in most parts of the country, there's still no beds available specifically to people with eating disorders. Now, if people require a certain level of intervention, it can be addressed probably at different levels. It's just that it has been an improvement over the last few years, and maybe there is more to think about and to consider as we move forward.
Thank you. We just have one last question here. I think that's everything. Saying my daughter is 12 and currently in inpatient hospital diagnosed with ARFID. Other than CAMS, is there any other services that we can avail of? This is all quite new to us as a family. And I just want to maybe use that as a way to signpost to all of our services that we offer here at Bodywise. So you're more than welcome to send us an email. We have a pillar program that provides psychoeducation and support to families. We have the Maudsley Carer Skills-Based Training Workshop Series. We have support groups, themed support groups. We also have incredible podcasts with Harriet and Jenny Langley. So please do reach out if you'd like some more support. And then maybe before we finish up, if you'd like to give some final thoughts, Muireann, John, and Anna. Thank you so much for joining us this afternoon.
Yeah, thank you for the invitation. It's a privilege to be asked to speak, and yeah, it's great to get to hear from yourselves in stream. I know we've had some people go to you, so we know you're doing great work there the other side of the country, and you know, as a service, we're very what's the word? More than grateful to Bodywise. I think you're such a wonderful resource. Yeah. And to all the families who came along today, I hope you got what you hope to get from it. And I'm sorry we can't answer those questions in as much detail as we might want to. Yeah.
Thank you. Thank you so much, Muireann.
And I think probably from our point of view, again, thanks for inviting us along. And it's very humbling to be able to speak to families. I suppose, again, this is only a drop in the ocean of the conversation we could have in this area. And I suppose going forward, what I would hope is that people will keep advocating, keep pushing for what's needed, because I think we need to be doing that right across the board. And hopefully at some point down the line, we would reach a state where maybe we can meet people's needs sufficiently. Again, being very mindful that that could be a long way down the road, but I think if people keep voicing their needs and advocating for their loved ones and for themselves, that hopefully we get there at some point.
And as Bodywise would say it, people with eating disorders can and do recover. And that's something that we can attest to. Thank you.
So lovely. Thank you both. And yes, hope is real, hope is there. So thank you everyone for joining us. And thank you to our speakers, Orla, Muireann, John, and Anna. I hope that this webinar was really helpful to all who have attended, and thank you for staying towards the end and even over. As I said, a recording will be made available online afterwards. And if you have any questions at all, please do reach out to us here at Bodywise. Email is pillar@bodywise.ie. Thank you so much, everybody. We'll leave it there.
Thank you. Bye.
Take care.
Everyone, bye.
Bye-bye.